Hello, I'm John Corrigan. I'm a professor in the Department of Physical Medicine and Rehabilitation at Ohio State University, and I'm the director of the Ohio Brain Injury Program. I'm pleased to be presenting this webinar today titled, What if There's a Traumatic Brain Injury? This webinar is jointly funded by the National Association of State Head Injury Administrators and the Ohio Brain Injury Program. By way of financial disclosures, I do receive funding from a number of federal funding sources, and I will be mentioning today an instrument called the Ohio State University TBI identification method that I developed with Jennifer Bogner, but neither myself, Dr. Bogner, or the university receive any financial benefits from the use or other distribution of this instrument. I'll be addressing 4 questions today. The first is, what if there's a TBI? And that'll be just some basics about what TBI is and how to think about it. What are the effects of TBI? Why would TBI be associated with behavioral problems? And that's really kind of the crux of why we're doing this webinar. And finally, how can you determine if a person has had a TBI? So first, what if there is a TBI? Let's start with definitions. So a traumatic brain injury, or TBI, is an insult to the brain. And it is not just any insult to the brain, but it's one that is caused by an external force. There has to be something external to the individual, like something hitting the head hitting something, or being shaken violently, that is causing this insult to the brain. We know that it's affected the brain because it results in an altered state of consciousness. And that's a very specific term, and we're going to be defining it in just a few moments. But one of the things to know about traumatic brain injury is that its effects may be temporary or permanent. And thankfully, the vast majority of traumatic brain injuries just have temporary effects. However, some are more permanent. And the real problem is we don't always know where the line is between a traumatic brain injury that will have temporary versus one that will have permanent effects. And we'll be talking about what are some of the criteria that make the effects of a traumatic brain injury more significant. So this is the injury triangle that the Centers for Disease Control has been publishing for a number of years. This is the most recent they have. And it shows the number of individuals who have died, been hospitalized, or treated in an emergency department each year in the United States for a traumatic brain injury. So just a little less than 3 million. However, that bottom row there says that there are an additional unknown number who receive other medical care or even no care for their traumatic brain injuries. And in some circles, it's suspected that that part of the triangle might actually look more like this. So it is a relatively high incident injury in the United States as well as other countries. So let me ask you a question. TBI is A, life-altering injury for survivors and their families, profoundly impacting the patient's functional status. B, a very common injury that is essentially inconsequential to the individual's functional status following recovery. Or C, both A and B and everywhere in between. And of course, you've guessed that the correct answer is C. And I want to thank Dave Arsenegas and Hal Warsaw for the inspiration for this little poll question. But traumatic brain injuries do indeed range from inconsequential and common to life-altering and thankfully quite a bit less common. But TBIs vary in severity, and that variation creates much of the differences in consequences that are experienced. We have a number of ways that we classify the severity of injuries, generally into mild, moderate, and severe. And thankfully, the actual distribution of injuries looks something more like this. Also, thankfully, you as a clinician don't have to know all these different ways of classifying a traumatic brain injury. And indeed, the one that is very useful, and we're going to talk some more about, is just looking at the length of loss of consciousness. So this is a continuum representing the severity from the least severe to the most severe traumatic brain injuries. And when we think about that altered consciousness that I mentioned that is part of the definition and has to be present in order for us to know there's been a TBI, the first way, the least severe alteration of consciousness, is when somebody is just dazed or confused or has a gap in their memory. So they might feel out of it for a moment. There was a time in sports we used to talk about having your bell rung. Or maybe later you realize, oh, I have a little missing piece. I don't remember what happened during that time, even though I was talking and awake and alert. So that's the least severe altered consciousness. That's followed, though, by actual loss of consciousness, where somebody is actually not aware of what's going on. Their eyes are closed. They have been knocked out. And that represents even more impaired functioning of the brain. The greatest alteration of consciousness then happens in coma. And coma is where the body is not only not aware and conscious of what's going on around, but doesn't even respond reflexively in automatic ways. So it would have been convenient if we had used this kind of basic description of the continuum of severity to classify mild, moderate, and severe, but we weren't quite that smart. Instead, when we talk about mild TBI, and by the way, a concussion is a mild TBI, it includes being just dazed, confused, or having a gap in memory, as well as actually losing consciousness, but not all loss of consciousness. Moderate TBIs then are the remainder of those injuries that result in loss of consciousness, and then severe TBIs are those that have the longest loss of consciousness or result in coma. This seems a little confusing, I know, but if there's just two milestones along this continuum that you can remember and keep in mind, you will know a lot about the severity of traumatic brain injury. The first is right here, the break point between being dazed or confused and actually losing consciousness. An injury in which there is loss of consciousness has greater odds of having long-term and more consequential effects. It's still a mild injury, but it's resulted in loss of consciousness. The second milestone is the separation between mild and then the more severe. And that's the point at which there are 30 minutes or more of loss of consciousness. And so if you just knew these two cut points, these two milestones along this severity continuum, there's a lot about injury that you would understand. Did it involve loss of consciousness? If it didn't, was it 30 minutes or more? This is not to say that a traumatic brain injury that does not result in loss of consciousness is inconsequential. And as a matter of fact, we're going to talk about some of the things that make even those very mild traumatic brain injuries potentially having more effects. So the first of those qualities, above and beyond the actual severity that we just looked at, is when there are cumulative effects from having multiple traumatic brain injuries. And we're not sure yet, we'll talk a little more about this, whether it's the actual number of TBIs you experience or if it's their spacing. And by spacing, what I mean in particular is if you've had a second traumatic brain injury before the first one has healed. And that may be what creates the cumulative effect more than the sheer number. You are very aware of places in society now where we are concerned about and have talked about multiple mild traumatic brain injuries. Of course, in contact sports, it's been much discussed. and also in our wars in Iraq and Afghanistan, where our service members were exposed to improvised explosive devices that resulted in blasts, as well as more conventional traumatic brain injuries. They experienced multiple mild as well. There's much we're still trying to figure out about what conveys this cumulative effect. As I said, is it the number, is it the spacing, or is it, even though mild, the relative strength of that mild TBI? Is it the type of injury? Are these high velocity or blast related injuries somehow conveying more cumulative effects? There's a condition called the subconcussive injury, and that's where the force has been exchanged with the brain, but it doesn't result in altered consciousness at the moment. And we do know from putting accelerometers, particularly into the helmets of football players, that sometimes great force is conveyed, but there's no signs of concussion. At other times with other players, there can be less force exchanged, and there is a concussion. So the question is, maybe that exchange of energy is what creates some of this cumulative effect. Whatever the cause, the mechanism of action is also unknown. Is this something? Do we have kind of like a pool of reserve or resource, and we're draining that reserve a little bit with each of these injuries, and at some point we go below a critical level? Or is it simply that it triggers some kind of process that takes a very long time to play out, or maybe both? And we do suspect, like with so many neurologic injury conditions, that there's a genetic or epigenetic effect. So some people may be more vulnerable simply by their genetic composition. What is important, though, to remember as clinicians is that it's not just military personnel or athletes involved in sports and contact sports in particular that may be affected by these multiple mild traumatic brain injuries. Victims of intimate partner violence have a very high rate of experiencing multiple mild traumatic brain injuries, often as a result of being hit in the head, particularly in the hair where bruises don't show. This may be combined with brain injury that's as a result of being choked or denied oxygen. Children who have been exposed to physical abuse. We do know that as people begin to misuse and particularly abuse substances, that the occurrence of injuries skyrockets, whether that's from stumbling and falling on steps, driving too fast or recklessly, or saying the wrong thing to somebody bigger than you in a bar. The individuals who are abusing substances have a much higher incidence of traumatic brain injury. And then there are other vulnerable populations, whether it's persons with psychiatric disorders, people in the criminal justice system, or those who are homeless. So multiple mild is not just an issue among athletes and our military service members, but affects other populations, particularly populations that we come into contact with as behavioral health providers. So after the cumulative effects, another dimension that adds consequence even when the injury is mild is one's age at the time of injury. We believe there is a developmental interaction. There's much more to be learned about this, but so far there's some suspicion that in very early ages, like before age 5, that there may be even greater consequence as a result of experiencing a brain injury. In adolescence, and particularly early adolescence, there may be more vulnerable of being injured at that time. And while so far the data is anecdotal, we think perhaps in normal aging among older adults, there may be kind of a critical period where a traumatic brain injury ends up being, even if mild, ends up being sentinel in terms of initiating and conveying greater consequences. Another aspect is we often forget is if you had one recently, you're more likely to be affected by it. If it hasn't had the time to heal, there will be more effects of it. We'll talk some more about what those effects are in a moment. But if somebody's had a relatively mild traumatic brain injury in the past weeks, or a more severe one in the past months or year, they are going to be experiencing more consequences just because of it being recent. And finally, kind of related to cumulative effects, but when a traumatic brain injury is combined with some other neurologic conditions, then the combination may be worse than either one alone. An example of that might be somebody who's an older adult who had a stroke previously and now they've had a traumatic brain injury, or a adolescent who has attention deficit disorder and then experiences a TBI. So these are all other factors above and beyond severity of the injury that convey consequences. So let's just recap. First, TBI occurs when an external force causes an alteration in consciousness. And we've seen what that spectrum of altered consciousness looks like. The effects can be temporary or permanent, and some of what contributes to us not knowing where the line is between temporary and permanent is that it's not just about severity, but some of those other factors we looked at. As we saw, they can range from mild to severe, and it's quite a range, by the way. Do not forget that a concussion is a mild traumatic brain injury. And as I've just indicated, there are these cumulative effects as well as the interaction with normal development that makes even mild traumatic brain injuries more consequential. Well, let's move on to our second question then. What are the effects of TBI? So typically when we talk about a concussion or a mild traumatic brain injury, these are the kinds of symptoms that people report. It's important to know that you won't have, it'd be very rare to have all of them. It might be one or two, it might be 3 or 4, but it would be pretty unusual to have had all of these effects. They are generally, some are more common than others, and roughly in the order that they are listed here. But one, for instance, does not have to have headaches as a result of a traumatic brain injury for it to have been a TBI. So these are the common effects. We generally would expect that we used to say 30 days, now we say 90 days, that whatever residual one is experiencing will have cleared up. However, if they don't, then we call that the post-concussive syndrome. And that simply means that the typical symptoms of concussion, as listed here, have not resolved within the time period that we would have expected an uncomplicated concussion to resolve. When we think about then longer-term consequences, and here we're talking about just a mild traumatic brain injury. There was a very in-depth study done by the Institute of Medicine, what was then called the Institute of Medicine, in 2009, where they were asked to look at what is the evidence for the persistent or long-term consequences, and they looked at it by severity of traumatic brain injury. And they use a very specific model for saying how much evidence is there, and in this case, these are consequences that were associated with mild TBI, where there was both evidence of association and evidence strongly suggestive of an association. And what I want you to see here, I've highlighted them in yellow, is the number of these consequences that relate to behavioral health. Depression has been widely reported and studied in the rehabilitation literature as a consequence of traumatic brain injury. More recently, aggression. We'll talk a bit more about suicide. And then, of course, the co-occurrence of TBI and post-traumatic stress disorder was brought to our attention by our service members in Vietnam and more recent wars. So while traumatic brain injury is a medical a condition that affects physical function, affects sensory function. It has a very heavy footprint of behavioral health consequences as well. Just to show you that in another way, this is a series of studies that we conducted in Ohio, where adult Ohioans who were non-institutionalized were surveyed randomly, and as part of that survey, we inquired about their lifetime history of traumatic brain injury. And what you see here is the relative odds that when compared to adults of the same sex, age, and race ethnicity, the relative increased odds of having these various conditions if you had had a prior history of traumatic brain injury that resulted in loss of consciousness. So not all the mild traumatic brain injuries, but from those with loss of consciousness and worse. And I've highlighted again in yellow those conditions that have a more behavioral health association. So in addition to depression and just overall poor mental health, we also see here greater likelihood of heavy drinking as well as cigarette smoking. And the addictions and generally impulsive behavior are often associated with the long-term effects of traumatic brain injury. So in addition to the quality of the consequences, what about just how common is it in society? And here are results of surveys done in 2 states, Ohio and Colorado, again where we ask about a person's entire history, lifetime history of traumatic brain injury. And they were a bit different. The Colorado survey was a bit more extensive. And what we see is that some 43% of adult Coloradoans, non-institutionalized, had had at least one traumatic brain injury in their life, meaning external force had altered consciousness. 1 in 4, roughly, with loss of consciousness, and some 6% had a moderate or severe. Very similar numbers in Ohio for loss of consciousness, a little bit lower, moderate and severe, but certainly within the same range. So that would be what you'd expect essentially from the general public if you just walked out on the street and started randomly pulling in adults and screening them for a history of traumatic brain injury. But what about when we go into some of our behavioral health treatment settings? What do we see? A series of studies we conducted in Ohio found that in our substance use disorder treatment settings that as many as 2/3 will have had a traumatic brain injury, more than half TBI with loss of consciousness, and some 17% more severe or moderate and severe traumatic brain injuries. One small study, and by the way, these are generally small studies and should not be considered of epidemiologic quality, but I think they do suggest a pattern we see here among psychiatric inpatients, and a series of studies among the homeless have similarly suggested that there's relatively high rates of traumatic brain injury. And if you just look at the most severe, what you see there is that in these settings, moderate and severe traumatic brain injury is 2 to 3 times as common as it is in the general public. So this behavioral health connection between traumatic brain injury is also evident in how prevalent it is in the populations we treat. I'm going to show you just a few slides here that kind of make the point about this connection between behavioral health populations and traumatic brain injury. This was the results of the series of studies we did in Ohio looking at different substance use disorder treatment settings, anywhere from the adolescent residential treatment, where the rate of loss of TBI with loss of consciousness was roughly 1 in 4. Not that different from the general population, but of course that's the entire general population, not just those, not just adolescents. The adolescents have not had the same opportunity over the rest of their life for traumatic brain injuries. But when we went into higher levels of care, whether it was adult residential, intensive outpatient, or Within our prison system, our therapeutic communities, we're finding more than half. And in one small integrated dual diagnosis treatment program, almost 3 in 4 individuals had had a traumatic brain injury with loss of consciousness. Much larger studies have been done, particularly in Scandinavia. We're going to look at a couple here where the entire population's medical histories and behavioral health histories can be compared. And this was a study just published about 5 years ago of 1.4 million people living in Denmark. And what they did is they looked at both medical history and psychiatric history. They excluded anybody who had a psychiatric diagnosis in their life before they had a traumatic brain injury. And then what they wanted to see is if you had a traumatic brain injury, how likely was it that at a later point you would have a psychiatric diagnosis. They were also not able to compare not just to the general population, but to individuals who had just had orthopedic injuries. And the reason for that is there's some suspicions that maybe this is kind of getting a traumatic brain injury is part of a risk-taking kind of predisposition that not only can lead to a TBI, it might lead to other broken bones and no TBI, but that it's really the risk-taking predisposition that causes the later consequences. So it's an important comparison group in that way. What we see from this study is that there was an extremely elevated risk of having a later psychiatric diagnosis if you'd had a traumatic brain injury, or head injury as they termed it. Those are the red columns you see. When that diagnosis was an organic mental disorder, it was extremely more likely. And that might be expected given that some association is being made between the onset of the psychiatric disorder and the traumatic brain injury, and thus the organic mental disorder diagnosis. But even when we're talking about schizophrenia, unipolar depression, or bipolar depression, all of the red bars, the head injury bars, are at elevated risk compared to the general population. In comparison to those who have orthopedic injuries, it is also elevated risk except for bipolar disorder. And in that case, both groups have greater risk than the general population. So another connection between traumatic brain injury and behavioral health is with suicide. And we're going to look at a few studies here. The first was a large Swedish study where they looked at the likelihood of dying by suicide after an individual had had a traumatic brain injury earlier in their life. And when compared to people of the same sex and age, they were 3 times more likely to die by suicide if they had a prior TBI. Even when compared to siblings who did not have the same traumatic brain injury, the risk was less, but it still was twice as likely to die by suicide. That's suggesting that even with the same household and environmental influences, the risk is double if somebody has incurred a traumatic brain injury. Another Scandinavian study, this one in Denmark, compared individuals who had had a traumatic brain injury and looked at their likelihood of dying by suicide. And the incidence was 2.5 times larger than same sex, age, and time period, people from the same time period, if an individual had a traumatic brain injury. When that traumatic brain injury was more severe, that risk increased to almost 3.5 times more likely, suggesting that there is kind of a dose effect with more severe TBI, greater risk. Finally, a relatively large study done here in the U.S., a number of healthcare systems, data combined from those systems, looked at various comorbid medical and psychiatric conditions and their relationship to dying by suicide. And in this case, when you control for age and sex and psychiatric diagnosis and substance use disorder, having a prior TBI increased your likelihood of dying by suicide by almost 9-fold. And this was the highest among all comorbid medical conditions. So another connection, and one that we've been particularly concerned about of late, is with traumatic brain injury and opioid use and opioid use disorders. And with my colleague Rachel Seiko Adams, we recently published a commentary suggesting that there was a combination of factors that made the opioid epidemic even more consequential for persons with traumatic brain injury. First among those factors was that it turns out that people with TBI are more likely to be prescribed opioids. Multiple reasons for that: more pain, whether headache or orthopedic related pain. The studies, particularly done in our active duty military members, found that those with persistent post-concussive symptoms were more likely to be prescribed opioids, and that among rehabilitation patients, persons in rehab for TBI, medical rehab for TBI, some 70% were given an opioid sometime during their stay. So they were more likely to get the opioids, but at the same time, they were more susceptible to the addictive influence of the opioids, and this is something we're going to be talking about more in a moment. And they face greater challenges in being treated for an opioid use disorder, or if that has developed. And what we suggested is that these three factors combine to make kind of a perfect storm out of the opioid use disorder crisis for persons with traumatic brain injury. So clearly, what we've seen here is that there is an association between this injury and behavioral health consequences or issues. But why would that be the case? And so we're going to talk about two sources of this relationship between traumatic brain injury and behavioral health problems. The first is the pathophysiology. It's essentially the nature of the damage that occurs as a result of traumatic brain injury. And the second is a neurobehavioral consequence. So essentially how we process rewards and consequences are changed with TBI that makes us more susceptible to behavioral health problems. So it is very important to understand that the fingerprint of TBI is that no matter where the blow comes to the head or what part of the head hits an object, the frontal areas of the brain are the most susceptible. And this is particularly the frontal lobes. It also includes the anterior tips of the temporal lobes. While there may be injury at the point of impact, there will also be injury in these frontal areas. And the reason for this is that when there's enough force or movement of the head, the brain, which is kind of floating in a gelatinous material, is inside the cranial vault and generally protected. But if you get enough force, it starts to jiggle or twist within that cranial vault. And thankfully, the undersurface of the skull, the inside of the skull, is smooth, so that with that shaking and that wiggling and hitting against the skull, there's generally not any additional damage. With the exception that in the frontal areas, there are some bony ridges that the brain can scrape or rub against when it is set into motion from an external force, when it is wiggling. And those bony surfaces can cause contusion or bruising in the frontal areas of the brain. So thus, this is one example. In this mechanical way, the frontal areas of the brain are more susceptible anytime there's kind of a force exchanged with the brain tissue. The result that we've known this from early autopsies to more recent imaging studies consistently find that when you look at the most common areas affected by traumatic brain injury, it's the frontal lobes, the anterior tips of the temporal lobes, and particularly that kind of undersurface there where what's called the orbital frontal lobe, that's on the kind of the bottom of the front. And what I would suggest to you is that if there was as a human, if there was any lobe of the brain that you didn't want injured, it would be your frontal lobe. And what you're seeing here is kind of a simplified list of the relationships between the frontal lobes and various abilities that what I think even a quick review suggests are essential to succeeding in society for humans. And indeed for humans, our frontal lobes, as a proportion of the rest of the brain, have the highest of any of the mammals, of any animals, actually. It is the part of the brain that develops the most from childhood into adolescence and early adulthood, and thus many of the connections we make there are connections critical to what we learn about being a mature and adult, successful in society versus a child. And so, these kind of problems like initiation, problem solving, judgment, inhibition of impulse, awareness of oneself, are all more common when the frontal areas of the brain are injured. And what I suggest to you lead to the kind of greater likelihood of behavioral health problems that we've been talking about. Now, I described a kind of a mechanical vulnerability of the frontal areas of the brain, but there are those who also talk about the frontal areas, and particularly specific systems in the frontal areas, being more vulnerable to traumatic brain injury, and that being due to these connections between the midbrain and the frontal areas. And some of you in the substance use disorder field may recognize this slide, not because it's one used to describe traumatic brain injury, but it's one used to describe the basis of addiction. And that particularly these systems, the dopaminergic pathways between the midbrain and the frontal lobe determine a lot what we find rewarding and how we respond to consequences. And that's really kind of the second area, the second mechanism I want to talk about here, and that's the neurobehavioral contribution, and in particularly kind of thinking about these behavioral problems as disorders of how we process rewards and punishment. And I'm going to use one example. It's something called delay discounting. This is just one example, but let me kind of lay this out for you. That if I ask you, which would you prefer? That 1 year from now, I give you $20, or 1 year and 1 week, I give you $22, most of us will do the math, say, okay, wait another week, earn another 10%. That sounds like a good deal. I'll take the $22 1 year and 1 week from now. But if I change that and I say, which would you prefer? That I give you $20 right now or $22 1 week from now, the vast majority of the general public switches their choice and says, give me the $20 right now. Now, this drives economists crazy. It's the same math. It's the same economics. Wait a week, earn 10%. But as humans, we are not quite so logical, and we will prefer the immediate receipt of the $20 over waiting a week for $22. The studies have been done of kind of what the brain is doing as it's making these various decisions. And what we found is that when you're thinking about a year from now, and let's see, is waiting another week for $2 more worth it, there's kind of one system in the brain that's engaged. But once we make it a potential for an immediate reward, another system gets involved. Not that the first one goes away, but the other system gets involved. And it has to do more with processing of immediate reward. And I don't expect you to understand the magnetic resonance imaging that's shown here, but the areas of the brain you may notice are some of the very ones that we were just looking at as being more likely to be affected by traumatic brain injury. The same areas of the brain that are part of this system that gets involved when an immediate reward is in play. And in particular, the part of that, the frontal lobes and the medial orbital frontal cortex shown there, what its job seems to be actually is to put the brakes on in this other system and say, oh, hold on, that reward may be immediate, but there are other things to consider here. Our orbital frontal cortex, many think of as kind of the brakes on our behavior, which allow us to delay an immediate reward to get a better reward later. Delay discounting is very similar to what we used to talk about in terms of delay gratification. But those parts of the brain that we just looked at that are part of the brakes are these very parts that we just a moment ago saw as being vulnerable to traumatic brain injury. So just to recap, first, regardless where the impact comes to the head or what part of the head hits first, the frontal lobes are the most likely injured. The frontal lobes are critical to behavioral control, and I would say in turn, the one's likelihood to succeed in society, but that also extends into the likelihood of succeeding in treatment, likelihood of being able to benefit from services and supports, and we'll talk a bit more about that. And in particular, there's greater impulsivity and disinhibition because of the way in which how we process rewards and consequences, our willingness to delay gratification versus go for the immediate fulfillment. So what I'd suggest to you, and I hope that I've given you enough here to support this statement, and that's that wherever we are working with individuals to try to assist them, if it's the mental health system, treating substance use disorders in the criminal justice system, it really is worthwhile to know if the person we are trying to assist has had a traumatic brain injury. And the reason it's worthwhile is that with that history, which may not be evident from either their medical record or what they tell you, what they share spontaneously or even know to share spontaneously, it may not be evident, but they are going to be more susceptible to some of these frontal lobe issues if they have this history. And we know from now a pretty large body of work that somebody with a traumatic brain injury participating in the behavioral health system has even greater challenges, that they are less likely to be successful, they are more likely to premature terminate, they often are labeled as non-compliant from the provider's point of view. From their point of view, they often indicate that they don't think this service or this treatment or this agency is going to be able to help them. They have a low sense of the likelihood of success. So that takes us to the fourth area I wanted to cover today, and that's that. Given you should know, how can you determine if a person has had a history of traumatic brain injury? So there are issues, and what we're talking about here is not did they just have a traumatic brain injury. That's a different kind of medical question. This is have they had enough or any or enough of a history of traumatic brain injury in a lifetime that you should be concerned that they would have some of these frontal lobe problems. So your first thought might be, well, let's get it from the medical record. There are a lot of reasons why that doesn't work well at all. To start with, most of us don't have all of our medical records in one place. Until such time as we have a chip in our neck that has our entire medical history, that probably is not going to be realistic. But even if it were, we now have several studies that have shown that mild traumatic brain injuries may be overlooked when a person has an injury and comes to the emergency department. In at least one study, it was found where research staff went in after the clinical staff had finished assessments in the emergency department. Research staff identified 50% more individuals who had a mild traumatic brain injury. And this is natural. I mean, if there's, if the arm is broken, if there's a bleed going on, that is the top, priority for the emergency department, is to address the life-threatening issue. So if a mild traumatic brain injury also occurred, maybe now, an hour later, it is not apparent, the altered consciousness isn't apparent, it would be easy to miss that it's occurred. So even medical records may not be adequate in time to get a thorough history of traumatic brain injury. Well, we have all this great technology now in medicine. What about a biomarker? There is great technology, and the advances in imaging are just incredible. And we have other methods like neuropsychological assessment that are very good at detecting alterations in one's cognitive abilities. But what it's important to understand is that a positive result from an CT scan or an MRI or even a functional MRI or a positive result from a neuropsych assessment is a good indication that a person's had a traumatic brain injury. But a negative result, where it doesn't find anything, is not an indication that there's been no TBI. These tests are what's called specific but not sensitive, so that there can be traumatic brain injuries that they do not detect. So what we should always be thinking about is that an image or a neuropsych assessment, a yes is a yes, but a no is a maybe. It still might have occurred. The reverse is the case with some of the new developments around blood serums and other proteomics being used to try to identify whether a traumatic brain injury has just occurred. And in that case, what happens is that they are sensitive, but they're not specific. So a yes is a maybe, but a no is a no. And while you might be able to imagine combining those two things to have a definitive answer, it's still unlikely that they would be useful in getting lifetime history of traumatic brain injury. They may be useful in getting a more acute injury. Well, then the third general area of ways of detecting is self-report, is to ask the individual, or in the case of children, asking parents, to kind of retrospectively think back and tell us, what kind of a history of traumatic brain injury have they had? Also not without problems. The first one, and the mistake we've made the most, is that we assume people can self-diagnose. So if you ask the individual, have you ever had a traumatic brain injury? Most people don't know what that is. And so the answer you're going to get is only as good as their understanding of what TBI is. And in the last 10 years, a lot of people at least know what a concussion is, if not traumatic. They know they exist, I should say, a concussion or traumatic brain injury. But they actually don't know what the specific diagnosis is. And before 10 years ago, nobody even knew what that was. So we can't ask people to self-diagnose. We have to do it another way. The other thing is just memory. not being aware of an injury. That can be anything from what's telescoping, and that's where relatively minor injuries, enough in our past, we tend to not remember them. A minor injury that happened more recently, oh yeah, we'll recall that. More severe injuries are less susceptible to telescoping. A person may have been too young when the injury occurred, particularly before the age of 5, as we'll talk about more, or just poor memory created by the injury itself may be a source of limiting how good somebody is able to provide a full recap of their lifetime history of traumatic brain injury. But despite these problems, at this juncture, this is still the gold standard for getting at lifetime history. Not for getting at an injury that's just occurred, but for getting at lifetime history. I've already mentioned a few of the challenges involved in eliciting these self-reports. Limited or inaccurate knowledge, which really undermines the ability to any expectation that a self-diagnosis is correct. Because of the memory problems, what we have found is it's really important to stimulate recall, to remind people of things that might have been associated or incidents that might have resulted in a traumatic brain injury, things that might have caused it, medical attention that may have resulted from it, stimulate recall, and then increase the ability to for them to tell you about the incidents in their life. Injuries before age 5 will probably always be a problem for self-report. However, we also have found that if the injury was more significant, resulted in going to the hospital, there was bleeding, a parent was extremely worried, those often end up part of the family lore and may be passed on as a story that's retold later. And so, it's important not to only rely on what a person remembers themselves, but also on stories they've been told. And another source is if there's something else causing altered consciousness at the moment. Amongst persons who have substance use disorders, they may be in blackout and also have experienced a traumatic brain injury, which sometimes can be sorted, teased apart, but other times cannot. Or let's say in a very traumatic situation, like in combat, or in an assault, the stress of the moment may cause some alteration or temporary confusion, and if the head is also hit, the question is, so which is which? And finally, what we've learned over the years is that not all individual brain injuries can be separated out. That for people who've had times in their life where they had multiple blows to the head, they may not be able to discern incident by incident, and in that case it might be more important to kind of look at the whole epic in their life. This can occur in domestic violence. This can occur in boxers or persons who played contact sports. So there have been over the years a number of instruments developed that have, in some cases, have a lot of research behind them. In other cases, not so much. All have attempted to be some kind of way of standardizing self-report. As I mentioned at the beginning of this webinar, Jenny Bogner and I developed an instrument called the Ohio State University TBI identification method. I'll mention a few more things about it, but I want to make sure you understand that it is just one of other options that are available. We did a series of studies, some of which are shown here, that tested its reliability. In other words, if you do it twice, you ought to be able to get the same results, or that's going to limit its validity. We also tested it against where we gave the instrument and then we did a whole series of psychological and neuropsychological assessments and looked at what kind of history is associated with current functioning. And that was initially our primary way of validating although since there have been studies that have looked at just the accuracy, comparing later self-report to medical records. More convincing, I think, is that there are now a series of studies that have shown a positive result on the OSU TBI ID from self-report is associated with changes in imaging, neuroimaging, and in at least one case, changes in serum levels of certain markers in the blood. So that this self-report is anchored to something that we know to indicate a change in the brain. So just briefly, I mentioned most of these issues, but what the OSU TBI ID does is it's a structured interview. It's brief. For most people, it's 3 to 5 minutes. What we do in order to not rely on self-diagnosis is we first do ask a series of questions to help people recall injuries in their life, not traumatic brain injuries, but injuries that involve their head or neck. And after kind of spurring their memory as much as we can to recall those incidents, then we go back and determine if they've had an altered consciousness. And we really think that that process of first spurring memory of injuries, then determining altered consciousness is kind of the secret sauce of how one gets a more valid and reliable self-report. And finally, also critical here is that it provides more than just a yes-no. Yes, they had a history. No, they didn't. Many of the early attempts to get at lifetime history just ask a single question with a yes-no answer. What we've learned since is that not all traumatic brain injuries result in consequences, and so we really need to know things like how severe was the worst one you had, how recent was your last one, how old were you in the first one you had. And those kind of indicators really are what help us understand whether the person sitting in front of us right now may be at greater risk of having some of those frontal lobe problems. Because that problematic history is going to make that person and the behaviors they show are going to result in more difficulty accessing services, remaining engaged in services, the premature termination I mentioned before, even knowing what supports they need, being aware enough of their own strengths and weaknesses to know what kind of services and supports are going to be effective for them, and consistently using those supports. That is the inconsistency with follow-through, whether it's making the next appointment, making it on time, following up with suggestions and things discussed from a previous appointment. Those are all problems that come with the frontal lobe issues we've discussed. And really all of these end up being barriers to successful treatment. Well, I want to thank you for having stayed engaged with this seminar, this webinar, and I hope you have gotten some sense of why we think it's important in the behavioral health field that our providers are more aware of what traumatic brain injury is, of this connection between traumatic brain injury and behavioral health problems, and as I just briefly introduced, that there are things you can do. First, to screen for it, know if your client has had a traumatic brain injury, and though not discussed today, some of the simple accommodations that can be made to make treatment more successful. Thank you very much.